Good evening.
So the topic for discussion is brachial plexus anatomy and the block that we can provide for shoulder surgeries and from sciencer. To start with the brachial plexus anatomy, the brachial plexus arises from the anterior primary rami of C5, C6, C7, C8, and T1 spinal nerves, and this network consists of 5 roots, 3 trunks, and 6 divisions, which are going to be 2 per trunk and 3 cords and 5 major terminal nerves. So the C5 to T1 nerve roots are going to emerge from their corresponding intervertebral foramina, and then they travel along the grooves and between the anterior and the posterior tubercles and corresponding to the transverse processes. So they finally emerge between the anterior and the medial mediastinal muscles above the second part of the subclavian artery, and they also posterior to the vertebral artery. So the C5 and C6 nerve roots usually unite to form the upper or the superior trunk, and the C7 continues as the middle trunk, and also the C8 and T1 is going to converge to form the lower, also known as the inferior trunk. These 3 trunks travel infralateral and cross the base of the posterior triangle of the neck and the first rib. And at the lateral border of the first rib, each trunk is going to bifurcate into an anterior and posterior divisions. So approximately at the level where these nerves course under the pectoralis minor muscle, the divisions converge to form 3 cords, the lateral cord, anterior divisions of the upper and the middle trunks, and the medial cord, which is going to be an anterior division of the lower trunk, and the posterior cord, which is going to be the posterior divisions of all the 3 trunks. These cords are grouped around the second part of the axillary artery within 2 to 2.5 centimeters from its center. So these are typically within the when you place an ultrasound probe in the transverse axis of these cords, the medial and medial cord lies to the inferior, and the lateral cord superior, and the posterior cord lies posterior to the first part of the axillary artery. Immediately beyond the pectoralis minor muscle, these 3 cords diverge into its terminal branches, and including the which includes the median, ulnar, radial, axillary, and the musculocutaneous nerves. So for the surgical purposes of the shoulder, the block that we would like to give for a patient is going to be the interscalene block. To start with the landmark procedure, which is going to be using the nerve stimulation technique. The landmarks are, there are actually 3 described the landmark blocks, namely the Winnie's, Mears, and posterior interscalene block, but we usually do the Winnie's technique. And the landmarks include using the interscalene groove is going to be palpated by rolling the fingers posteriorly off the lateral border of the sternocleidomastoid muscle, which is going to mark the groove as high as possible. And once a prominent transverse process of the C6 can usually be felt in the groove and should be marked. So while needling, we need to make a wheel in the interscalene groove at the level of the cricoid process. Using a 22 gauge needle, which should be at least 36 to 50 mm insulated needle, has to be introduced through the wheel, and the needle is directed medially, caudally, and also slightly posteriorly to the direction of the C6 transverse process. The caudal tilt of the needle is important so that we can avoid entering into the neural foramen and injection into the dural nerve roots. And these are the superficial structure of the plexus are located at an average shallow depth of 5.5 mm due to the compact arrangement of the nerve anatomy, and has to be angled may be needed in these patients to avoid puncture of the vertebral artery or epidural or subarachnoid space. The nerve localization can be done by applying an initial current of 0.8 milliampere, usually sufficient for stimulating the plexus. and usually at the depth of 1 to 3 centimeters, and current is reduced to aim for a threshold current of around 0.4 milliamperes before injecting, and after obtaining the injection has to be carefully given after careful aspiration, and a 25 to 30 ml of local anesthetic has to be injected in small increments to detect the intraneural or intravascular placement of the needle. Using an technique, there are two scanning techniques that are recommended in viewing the brachial plexus at the interscalene level, which is to begin anteriorly at the level of the cricoid cartilage level, and movement from anterior and medial to posterior and lateral toward the interscalene groove. And the other technique is to scanning from proximally from the supraclavicular fossa to the interscalene location. So here the appearance is going to be at the supraclavicular fossa. The brachial plexus trunks or divisions can be seen in the short axis, and it is tightly enclosed clusters like a honeycomb cluster is seen, and superior and lateral to the subclavian artery. So after proximally tracing the nerve towards the interscalene groove, the nerve structures, which is the root or trunk, are visualized in the sagittal oblique section of the tree, which can go up to even 5 rounded or oval shaped hypoechoic structures. And the needling techniques can be done by after making and giving a local anesthetic to the skin where you are anticipating a needle puncture, and a 22 gauge 50 needle is usually recommended, and the needle it can be done through the in plane or out of plane techniques. The local anesthetic spread has to be visualized throughout the procedure, and continuous aspiration for every 5 ml is recommended, and the hypoechoic fluid expansion can be seen through the ultrasound probe too. The major side effects for these procedures include a phrenic nerve block, which is seen in almost 100% or more than 80% of the blocks that are given through the interscalene blocks. A recurrent laryngeal nerve block is seen in up to 15% of the patients, and stellate ganglion block or Horner syndrome can also occur in these people. Epidural or spinal injection or spinal cord injury can also happen, and the vertebral artery injection can occur, and even 1 to 3 ml of local anesthetic solution, which can precipitate seizures if directly given into the vertebral artery. Intravenous injections can occur, and bilateral spread of the interscalene block can happen, and a pneumothorax, if the needle is advanced in a lateral direction, the pneumothorax can also happen. Also, C6 neuropathy is also possible in these patients, and there is the contraindications for doing these blocks include it's better not to do in an anesthetized patient, also patients who are with COPD or a unilateral phrenic nerve palsy. Moving on to the Froment sign. Froment sign is nothing but a ulnar nerve palsy which affecting the adductor pollicis muscle, and to elicit the sign of this, to elicit the Froment sign, the patient is asked to grasp a piece of paper between his thumb and the index finger like a key pinch, and the examiner tries to pull the paper away from the patient. So a positive sign is when the patient, instead of holding the paper with the adduction of the thumb, the patient flexes the interphalangeal joint like this, and using the flexor pollicis longus, which is a median nerve supply, to compensate for the ulnar nerve weakness. So this is called as a positive Froment sign.
Okay. Only correction here is whenever the question says describe any one technique of blocking this, either you stick to the use of peripheral stimulator, or you start describing the ultrasound guided block.
Okay,
Okay,
sir.
so that you can save time, especially when you are writing a long theory paper. If
Okay, sir.
you describe both the peripheral nerve stimulator technique as well as the ultrasound technique, you will be wasting a lot of time.
Okay, sir.
So you will not be penalized for describing one particular technique correctly in toto. So that the question wording is very important. You can avoid loss of time by restricting yourself to the and
Okay, sir.
why it is preferable to use the interscalene approach for shoulder surgery? What is the reason?
Sir, so that branching occurs an axillary artery which comes out of the radial the axillary nerve which comes out of the radial nerve is going to supply the deltoid muscle, sir. So blocking it higher up can provide analgesia over the deltoid region and also the shoulder region, sir.
Is that the reason? Main reason? Is there any other supply to the shoulder other than the axillary nerve?
Supraclavicular nerve.
What about supraspinatus and suprascapular nerve? They also supply. No? They are all branches taking up at the higher level. So they also arise from the brachial plexus. And so by giving or close to the root where the branches are coming, that is the reason why the shoulder surgeries are better tolerated by interscalene rather than by the classical supraclavicular. Okay, so you have to mention the branches that are given up at the root level, at the trunk level, at the cord level, apart from the 5 major branches that are given as a terminal branches: median, ulnar, radial, axillary, and the musculocutaneous. All these 5 are considered as the 5 major terminal branches.
Okay.
The other branches that are given at the earlier level also required to be described in the description of the anatomy of the brachial. Okay, right.
Yes.
So it's a presentation. I'll just go to show you